Hello, my name is Aran Toshav, and I'm the Academic Director of Abdominal Imaging in LSU in New Orleans. And this lecture on abdominal and pelvic trauma is actually a condensed lecture that would usually be 3 to 4 lectures that includes Dr. David Smith's lecture on injury to the solid organs, as well as Dr. Marshall's, who is one of our interventional radiologists and our program director for interventional radiology, his discussion on when to intervene and what are the signs to alert the trauma service that intervention may be necessary. So with that, we have nothing to disclose relative to this conversation, relative to this talk. So our goals and objectives, hopefully by the end of this talk, you will be able to recognize and grade solid organ abdominal trauma. Hopefully you'll be able to identify the findings of bowel mesenteric injury. You'll become more familiar with CT findings and interventional implications, and be able to recognize some of the signs of penetrating trauma. So with that, we'll jump right into AAST organ injury scale. So why is this important? Blunt abdominal trauma is a leading cause of morbidity and mortality among all age groups, and contrast-enhanced CT is the modality of choice for detection of these injuries. When we're talking about AAST grading criteria, why do we do this? Well, we do this because it's necessary for our trauma center to maintain its accreditation. Our trauma service has asked us to place in our dissertation the grading of all the solid organ injuries that we see. And as part of that, it's very difficult to remember all this. So we have a little cheat sheet by our workstation in the ER that basically lays out all this for us. The important part from this slide is to sort of have a little bit of discussion on what are some of the findings. So a vascular injury is defined as a pseudoaneurysm or an arteriovenous fistula that appears as a focal collection of vascular contrast that decreases in attenuation with delayed imaging, whereas active bleeding from a vascular injury is going to present as vascular contrast focal or diffuse that is going to increase in size in delayed imaging. You're going to grade based on the highest grade assessment on that imaging at either or on that imaging or at operation or the pathologic specimen. And if there's more than one grade, it's going to be the higher grade of injury that you select. And you can advance one grade for multiple injuries up to a grade of 3. So let's jump right into this. So grade 1, what does that look like? Grade 1 is the subcapsular hematoma with less than 10% of the hepatic surface area. And you can see that in the top image where there's that focal area of hypoattenuation indenting the liver capsule that's less than 10% of the surface area. Whereas a parenchymal laceration that's less than 1 centimeter in depth is that linear hypoattenuation that's extending in from the capsule surface where the yellow arrow is on the bottom image. You can also see there's a little bit of perihepatic hematoma as well. Grade 2 injury is going to have a subcapsular hematoma, which is between 10 and 50% of the surface area, or an intraparenchymal hematoma that's less than 10 centimeters in diameter, as you can see from the top image, where there's an irregular hypoattenuation that's less than 10 centimeters in diameter in the right hepatic lobe. A laceration that's between 1 and 3 centimeters in depth will also get you a grade 2 measurement, and you can see that that goes up to 10 centimeters in length. As you can see in the bottom image, there's a laceration that's approximately 1 to 3 centimeters in depth. A grade 3 injury to the liver is going to be a subcapsular hematoma that's greater than 50% of the surface area, a ruptured subcapsular parenchymal hematoma, an intraparenchymal hematoma that's greater than 10 centimeters, or as you can see from the top image, a laceration that's greater than 3 centimeters in depth. On the bottom image, you're seeing a focal area of hyperattenuation, which is active bleeding, and that is also part of the grade 3 grading as well. Grade 4, so we already here in this patient, you can tell this patient was hemodynamically unstable, right? So they went straight to the OR, and our trauma bay actually converts to an OR as well. So sometimes we don't on these severe trauma injuries, we don't even see them until after they come out of the OR. But you're seeing in the left hepatic lobe parenchymal disruption involving anywhere between 25 to 75% of a hepatic lobe, and or active bleeding extending beyond the liver parenchyma into the peritoneum. A grade 5 injury is a parenchymal disruption of greater than 75% of the hepatic lobe, which is what you're seeing here, where there's nearly complete hypoattenuation involving nearly the entire liver, certainly of most of the right hepatic lobe. That or juxtahepatic venous injury to include the retrohepatic vena cava and central major hepatic veins. Splenic injury uses almost all the same terminology, and the grading system goes the same way as it did for the liver. So with that, a grade 1 injury, which is almost barely imperceptible on this study, is going to be a subcapsular hematoma that's less than 10% of the surface area. As you can see, there's a little bit of fluid and stranding. That's less than 10% of the surface area of the spleen, posterior to the spleen. You could have a parenchymal laceration, which is less than 1 centimeter in depth, or you can have a capsular tear. A grade 2, as you can see here, there's a parenchymal laceration that's between 1 and 3 centimeters, or you can have a subcapsular hematoma that's less than 10% of the surface area, or an intraparenchymal hematoma that's less than 5 centimeters. A grade 3 injury can be a subcapsular hematoma that's greater than 50% of the surface area, a ruptured subcapsular or intraparenchymal hematoma greater than 5 centimeters, or in this case, a parenchymal laceration that's greater than 3 centimeters in depth. As you can see by the more posterior arrow is pointing to that 3 centimeter depth. The grade 4 injury is any injury in the presence of splenic vascular injury or active bleeding confined within the splenic capsule. You can see there are 2 areas of hyperattenuation within the spleen confined to the capsule, indicating active bleeding. Parenchymal laceration involving hilar vessels producing greater than 25% devascularization. And here's a case that had parenchymal laceration involving the hilar vessels producing a greater than 25% devascularization. As you can see, the hypoattenuation involving a large portion of the anterior aspect of the spleen. Any injury in the presence of a splenic vascular injury or active bleeding confined within the splenic capsule would also count for grade 4. And then finally, grade 5, the shattered spleen, which is basically what you're seeing. And any injury in the presence of splenic vascular injury with active bleeding. As you can see, there are multiple areas of increased attenuation in the spleen, indicating active bleeding. There's very little spleen that is perfusing normally on this image. So with that, we're going to turn to renal injuries. Again, the grading classification is very similar to the other solid organs we just discussed. And we can move on to discuss. So a grade 1 is going to be a subcapsular hematoma and or parenchymal contusion without laceration. You can see this focal area of hypoattenuation in the posterior aspect of the left spleen. It's barely perceptible. So that is a small subcapsular hematoma. Whereas grade 2, you're going to have a perirenal hematoma confined to Gerota's fascia, or you can have a renal parenchymal laceration that is less than or equal to 1 centimeter in depth without urinary extravasation. So I'm not providing you with a delayed image, but you'll have to take our word. There's no urinary leakage here, and you can see that there's about a 1 centimeter area of linear hypoattenuation in the posterior aspect of this left kidney. A grade 3 injury is going to be a renal parenchymal laceration that's greater than 1 centimeter in depth without collecting system rupture or urinary extravasation. Here we have a kidney where there's a large portion of the anterior aspect of the kidney that is no longer being perfused. There is surrounding perirenal hematoma. And if there were any injury in the presence of renovascular injury or active bleeding contained within Gerota's fascia, would be included in a grade 3 lesion as well. A grade 4 lesion is going to be a parenchymal laceration extending into the urinary collecting system with urinary extravasation. So here we have a delayed image. The arrow is pointing to the dense contrast that is extravasating from the urinary collecting system. There's large portions of parenchymal laceration. The kidney has perirenal hematoma. Grade 4 would also include a renal pelvis laceration and or complete uropelvic disruption, segmental renal artery, vein, or arterial injury, active bleeding beyond Gerota's fascia, segmental or complete kidney infarction due to vessel thrombosis without active bleeding. And finally, grade 5, where you have a main renal artery or vein laceration or avulsion of the hilum. You can see here in this picture, the right kidney is not enhancing relative to the left kidney. You can see that There's only a portion of the right renal artery that is opacified. There's hematoma surrounding the renal vascular pedicle, and this is a devascularized kidney. And there's also active bleeding or shattered kidney with loss of identifiable parenchymal renal anatomy would also be included in grade 5 diagnosis. All right, moving our attention to bowel trauma. When we first started giving this lecture, I asked our head of trauma surgery about the subject of subtle bowel injury. And he said, well, that's the nemesis of trauma surgery. And basically, when we dictate on our CT scans, there's a small amount of fluid in the pelvis, can't exclude occult bowel injury. You basically put these patients in a black box because findings of bowel injury can be subtle. The symptoms of devascularization injury do not show up for several days after the initial injury presents. And they're fearful of sending a patient out who may have this occult injury. And so they keep them in patients in-house for either re-imaging or to monitor them. So the patient hospital stay is delayed and for several days to ensure there's no delayed presentation of bowel mesenteric injury. And my final words of wisdom are, think about, I'll talk in a second, I'll talk about mechanism, but think about fixed segments of bowel. So where the retroperitoneal, duodenal, jejunal junction, and the ligament of Treitz, and the terminal element, there are a particular risk of injury because of shearing forces. And again, these findings can be difficult in the absence of pneumoperitoneum. So to understand bowel injury, it's important to understand the mechanisms of injury. So I think we understand deceleration, and what that's going to cause is mesenteric tears. And again, the things that we are going to think about are splanchnic vessel injuries that are fixed portions of the bowel and that are particularly at risk in shearing forces. You can have a crushing force, which is what we're seeing with the solid organ injuries, which is crushed between the anterior abdominal wall and the vertebral column or posterior thoracic cage, and that's the spleen, liver, kidneys are especially vulnerable. And then finally is a sort of more nebulous concept of the external compressive forces, which is a sudden and dramatic rise in intra-abdominal pressure that'll culminate in a rupture of hollow viscous organs. So while liver and spleen can also be affected, small and large bowel can be affected by this mechanism as well. So what does this look like? This was a 74-year-old male who was involved in MVC. You can see there's on the first axial image and the coronal image, there's a little bit of mesenteric infiltration with focal haziness and fat stranding. There really isn't any pneumoperitoneum on this image, but there was dense free fluid along the right paracollar gutter extending to pelvis with no associated solid organ injury. There's no injury to the liver that would account for this. And this ended up being an ileocecal mesenteric tear with ascending colonic ischemia. So there are no actual signs of the ischemia in the bowel on this initial imaging, but just the presence of the mesenteric tear was the clue that there may be underlying bowel injury in this patient. Likewise, this was a 69-year-old pedestrian who was involved in MVC. And you see there's a short segment of right lower quadrant small bowel that's a little bit thickened. There's some wall thickening, but notice especially that there's irregularity and prominence of the mesenteric vessels, and there's high dense fluid around the mesenteric vessels. And this is just to drive home to the point that the distal ileum near the ileocecal valve is a common site of injury. Deceleration forces induce shear, and this turned out to be a terminal ileum hematoma. This is a 55-year-old involved in MVC, and the axial images demonstrate this thick wall loop of small bowel, as evidenced by the yellow arrow. There's also some mesenteric fluid. It was a little bit of high density, but there was also normal caliber small bowel segments, which are the purple arrows immediately adjacent to this. And this ended up to be an isolated mesenteric laceration, and that can present as bowel wall thickening secondary to interruption of arterial or venous drainage. Finally, a 33-year-old motorcycle involved in MVC. There's a small amount of fluid in the pelvis. There's a normal appearing loop of small bowel with normal enhancement. There's a mildly thickened loop of bowel with decreased enhancement in small bowel feces sign. The coronal images demonstrated some mild stranding in the sigmoid mesentery. There was no significant colonic wall thickening. But then 2 days later, now this loop of small bowel is thickened. The sigmoid was decompressed, and there's a little bit of stranding in the sigmoid mesentery, but now there's more increased hyperdense fluid in the pelvis. And this person turned out to have an ischemic distal ileum and sigmoid colon that was ischemic as well. Similarly, in this patient, patient had a CT scan. There was hypoattenuation around the sigmoid colon. It was isolated. You can see with the yellow arrows, it's relatively hypoenhancing relative to the adjacent colon. Again, there's dense fluid, as evidenced by the purple arrow immediately adjacent to this loop of bowel. And this person ended up having devascularization injury of his sigmoid colon as well. So devascularization patients do not get sick for several days, and devascularization is more common in small bowel than in large bowel. And my final slide is this. So this was a 35-year-old male with an MVC of, it was in an MVC and had a GCS of 15, right? He should have had a normal, relatively normal CT scan. But you notice on his delayed phase imaging that his kidneys are not excreting contrast. And the question is, why is a kidney not excreting contrast? And the reason that we've come to see is that a lot of these patients who are hypovolemic, either because they're in shock or they're crashing or they're having another event, such as a myocardial event superimposed on their trauma, we see that often as manifested by their kidneys not excreting on delayed imaging. So be sure to be wary of hypovolemia, signs like shock bowel, decreased caliber of the IVC, hyperenhancing adrenals, poor excretion of contrast on delayed imaging. Which leads me to when to know to call the interventional radiologist. So when are patients hemodynamically unstable? Here you have a selective angiogram from that same patient whose kidneys were not enhancing on the delayed imaging. So this was a 37-year-old male in a scooter crash, taken to OR for liver and spleen laceration, bowel injury, and pelvic packing. He remains hypotensive and tachycardic. And according to the Eastern Association for the Surgery of Trauma, patients with pelvic fractures and hemodynamic instability or blood loss should be considered for pelvic angiography with embolization. Patients with arterial intravenous contrast extravasation of the pelvis by CT may require pelvic angiography and embolization, regardless of their hemodynamic status. And those are level 1 recommendations. So you have here in this 37-year-old male who was in a scooter crash, extravasation from the left obturator artery, where you can see the high dense fluid in the pelvis on the delayed imaging and initial imaging. He went for selective angiography, and as you can see in the lower part of the center of the image, there's an area of blush, indicating an area of bleeding. So this person went on to have gel foam embolization of the anterior division of the left internal iliac artery. As you can see from the images after the embolization, the bleed is no longer seen. And here's another post image showing that the bleed is no longer present. The second case is a 21-year-old male who was hit by a car traveling around 25 miles per hour. He had a CT with contrast that showed a grade 4 splenic laceration. His hemoglobin went from 15 to 10. His heart rate went from 85 to 121, and his blood pressure was dropping. So splenic embolization is indicated in hemodynamically stable patients with active bleeding from splenic injury as an adjunct to non-operative management. Non-operative patients spend less time on the ventilator, 0 days versus 2 days for splenectomy, have fewer infections, and have no difference in mortality when similar patients are matched and compared. So here we have the laceration through the spleen with small foci of contrast pooling in the spleen. This is a celiac artery angiogram showing enhancement of the spleen on the patient's left side, and there are just innumerable foci of contrast pooling within the spleen, indicating vascular injury and active bleeding. A splenic artery angiogram with the catheter in the mid portion of the splenic artery for coil embolization planning. The still image shows the anatomy of the splenic artery branches, including the short gastric arteries and dorsal pancreatic arteries. And you can see, as you can see in this diagram, so embolization decreases flow perfusion pressure and promotes hemostasis. And so here is the post-embolization with coil images. Contrast reaches the splenic artery through collaterals, including short gastric arteries and the dorsal pancreatic arteries. Finally, penetrating trauma. Common organs injured are the small bowel, 50% large bowel, 40% liver, 30% in intra-abdominal vascular, around 25% close range. There is more kinetic energy than those injuries sustained from a distance. Most gunshot wounds typically have a linear projection. The high energy wounds are associated with unpredictable injuries. There may also be secondary missile injuries from bone to bullet fragments. Stab wounds that penetrate the abdominal wall are difficult to assess, and occult injuries can be missed, resulting in delayed complications that can add to morbidity. So with that, I'm going to basically focus about the fact that a lot of times we don't even see these patients. They have initial imaging of a plain film, demonstrates a bullet. They know there's an open wound. They'll go straight to the OR, and then we'll either see them for re-imaging, or we'll see as the unpredictable findings that you miss because the trajectory of the bullets and their high energy are difficult to assess what injuries they're going to have. So this was a 25-year-old male who came to us 1 month after a lap repair of his rectum for a gunshot wound. And you can see as we imaged through his pelvis, there was this large collection throughout his abdomen and pelvis. And it went all the way down to his rectum, and we assumed that it was an anastomotic leak from his repair of his rectum. On his delayed imaging, the kidneys were not really excreting contrast. And it was, we made note of it, but we weren't exactly sure how to explain it. When he came to the interventional department to get his drain 24 hours after we did the initial imaging, lo and behold, there was all this contrast. And now you could see the full extent. You could see the trajectory track, and you could see that it was dense contrast. You know, if it was the vascular contrast, you would expect it would be following the blood pool, but this was following the contrast of the ureters. So this turned out to be a left ureteral injury that was missed at the time of surgery, partly because of the compartment they were in, right? They were in the rectal, perirectal space. They probably were not assessing whether or not the ureter was injured. And this is an image from a antegrade nephrostogram showing that there's extravasation of contrast from the distal ureter. Likewise, this is a 20-year-old male who has status post gunshot wound. We see where the ballistic fragment is. The patient went straight to the OR. Repeat, they brought him down. After he went to the OR, they had a drain in his abdomen. And you can see there's this metal artifact overlying where our IVC and aorta are. And it becomes hard to see whether or not there's a vascular injury. There's already a lot of blood in the abdomen and pelvis. As you scroll through, you can start to see that there may in fact be a communication between the aorta and IVC, and that's what you're seeing here on this image. You're seeing a aortocaval fistula from the bullet that the aorta and IVC are communicating, and you can see the trajectory of the bullet as well as the hematoma in the posterior subcutaneous soft tissues on the left, as well as in the perirenal space with the left kidney being pushed anteriorly. And this patient actually miraculously survived. He went on to get an angiogram and to have this fistula repaired. The most common cause for these aortocaval fistulas is going to be spontaneous rupture or erosion of an abdominal aortic azimuth. It's not going to be traumatic. They're usually associated with a high level of morbidity and mortality. They can be iatrogenic. So when it comes to penetrating trauma, it's more likely we're looking for the weird and the things that may have been missed a lot of times, and that's what we get asked to look at for penetrating trauma. So in conclusion, hopefully you understand the importance of grading solid organ trauma. You can recognize some of the signs of bowel injury and recognize the implications for interventional radiology consultation. from the initial imaging. Thank you.